Welcome to the Royal College of Physicians Edinburgh Clinical Conversations podcast. Each episode within this podcast series, we delve into a different medical topic with an expert speaker to join us. If you want to find more about the Royal College, then please do head over to the RCPE website and have a look at the education stream and see if membership would work for you. It offers a host of educational updates and activities such as the evening medical updates, the Royal College Symposia, and many more. Please don't forget, if you listen to our podcast, to give us a rating on one of the podcast platforms or subscribe so that it can come directly into your podcast stream.
Hello everyone, and welcome to another episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainees and Members Committee. My name is Dr. Marilena Giannoudi and I'm on the TNMC, and today I am delighted to be hosting an episode on the Inherited Cardiac Conditions Clinic with Dr. Anshu Sengupta as our guest. He is a consultant cardiologist at Leeds Teaching Hospitals. So Anshu, thank you so much for joining me today.
Thanks very much, Marilena. Thanks for giving me a chance to have a chat to you about ICC.
Thank you so much. Something that I know you're very interested in. So I guess the first question would be then, what exactly is your job role with regards to ICC?
Yeah, so it's one of a few things that I do. So I subspecialize in inherited cardiac conditions. In short, we refer to that as ICC in cardiology, as well as heart failure and cardiac MRI. So I guess I come from a more non-invasive side of cardiology, although of course I'm trained as a consultant in the UK in terms of background acute cardiology.
Okay, great. I've said this before and I think I'll keep saying it. Speaking to lots of juniors, cardiology tends to be something that scares them. And I think ICC can be quite scary, especially when we're dealing with uncertainties, arrhythmias, big families, and lots of, attention to detail. So I think the first kind of question is, what is an ICC clinic? What kind of patients do we see? What is the service designed to offer?
Okay, that question is one that will probably vary in its answer depending on where you are in the country, because it is run differently in different places. So I think broadly there are 5 domains of things that can be inherited that can affect your heart. So there's cardiomyopathy, heart muscle disease. There's ion channel disease, so a bit more of a kind of inherited arrhythmia feel. There is aortic disease, so aortopathy will sometimes be seen in an ICC service. Again, it depends from place to place. There are a lot of neuromuscular conditions that affect the heart, so you'll be aware of things like myotonic dystrophy having cardiac manifestations, and we all know about a few of those from PACEs, for example. And it's one of many different types of dystrophic condition that will often be seen by perhaps a neurologist or a respiratory person in an MDT. And cardiology will be part of screening or managing heart involvement, and that can be, again, muscle or electrical. And in the 5th group, which is largely in the UK not looked after by cardiologists, is inherited lipid conditions. So that is often done under the auspices of biochemistry or endocrinology or other area within medicine. My particular location is Leeds, so we run a regional ICC clinic which encompasses West Yorkshire, a lot of North Yorkshire, and for some areas at East Yorkshire as well. And we primarily do cardiomyopathy and ion channel disease within that. And an ICC clinic will involve people who have expertise in looking after those conditions from a cardiology angle. In our side, that is consultants who between us have interests in heart failure, cardiac imaging, and cardiac electrophysiology, device therapy, pregnancy. So we've got all of that represented within our cohort of 3 consultants. We have an aorta clinic, which is run slightly separately to the main ICC service. And we screen patients for neuromuscular cardiac involvement as well within that same structure. And an ICC clinic is complete once it's got some other groups. So we have specialist sonographers, specialist nurses. We have pediatric cardiologists, and so we have a transition process of patients who were seen during their pediatric care, then moved into adult care with an active process of transition at the age of 15 to 16. And we've also got genetics. That's consultant geneticists who have trained, again, often by the MRCP, IMT, CMT pathway, but they can come to it from different routes like general practice or pediatrics. And we also have genetic counsellors and various other people within the genetic structure. So that group of people together is what you would sort of call an ICC service or an ICC clinic. And depending on where you are and what expertise you've got, you will see certain types of condition within that from those, or in the UK, broad domains.
How is a patient picked up by the ICC clinic? Is it that, you have a patient with symptoms that comes, or is it that you have a family that's referred and then it's screening from that point of view?
So both of those things, those are the two main kind of angles. So you either have a referral from a clinician with somebody who may or may not have a diagnosis. So sometimes it's to confirm a diagnosis that's not entirely clear. Sometimes it's a very clear diagnosis. So someone comes in with chest pain, they've got an abnormal ECG, and their echo shows that they've got hypertrophic cardiomyopathy, for example. That would be the commonest inherited cardiac condition. Or they come in with an arrhythmia and they've got prolonged QT, and you think they've got clinical long QT syndrome without any triggers. So, for example, they don't have a medication that's the explanation for it, or they don't have a significant electrolyte abnormality. So you might have that kind of diagnostic pathway. The other thing that happens is the patients are highlighted either through the ICC clinic or through some other means, and then we would recommend that they have family screening in certain circumstances. So the ICC service might then also provide that screening. The other type of broad pathway is sudden arrhythmic death syndrome as well. So if somebody has had a post-mortem, and this is where actually I should have mentioned that histopathology and autopsy pathologists are part of a high-quality ICC service as well. And if they have flagged that there's no obvious cause of death, there's nothing on histology in the heart, then there might well be some kind of arrhythmic cause. And you might then have to cast a relatively wide, judicious net of investigations and family members. So there's lots of different settings for family screening. And that can, in certain circumstances, also include genetic testing.
I think my question about what investigations would be needed is probably not very well placed, because it sounds like it very much depends on which of the 5 categories you fall into and the kind of clinical scenario around the patient and their family. So I guess I'll rephrase my question to say, if there is suspicion of an underlying structural problem, are all patients subject to both echo and MRI? Or again, is it on a patient-by-patient basis? What do you need for that diagnosis?
The answer to that question in almost every setting is that you don't necessarily need an MRI. And I say that as an MRI doctor. And I think echo is still the workhorse of most of cardiology, quite rightly. There's a lot of times when your diagnosis can be made with echo. So you get a good quality echo with decent imaging, you'll be able to diagnose, for example, a dilated cardiomyopathy. You'll get chamber dimensions, you'll get systolic function, and you can get an awful lot more. There are times where the MRI is required for really basic reasons and that the echo windows are really bad, and you might just need an MRI to actually visualize the structures that are needed. But there's a lot of situations in which an MRI will provide additional information. So whether that's to refine the diagnosis, or whether that perhaps is to exclude a phenocopy. So you've got a normal echo, very funny ECG, doesn't really fit long QT syndrome, but your MRI might highlight some scar in the lateral wall that explains why the T waves look a bit odd. So it can be for that purpose. And there's a lot of data nowadays for the role of fibrosis in determining risk in various types of condition. And depending on which condition you're looking at, being able to do tissue characterization of the myocardium using an MRI can give you a bit of additive information that will help you decide on the risk of sudden death. Because as you alluded to earlier, that can be unpredictable and uncertain. And so whatever mechanisms you have to try and refine that risk, the more, I guess, happy you might feel with the risk that you quote the patient, and the more information you have feeding into that.
On the other side, if we think that the underlying condition is arrhythmogenic in nature, other than an ECG and an echo, what is the main investigation, if any, that these patients need?
So again, it'll be a little bit dependent on the condition. Most of the time when you're looking for some sort of electrical condition, it's quite helpful to have a 24-hour ECG. depending on what you're looking for, that might be, for example, ectopic counts. So there's a condition called arrhythmogenic right ventricular cardiomyopathy, ARVC, which can have a bit more of a structural feel, or it can have a bit more of an electrical feel. And if you have more than 500 ectopics in 24 hours, that's one of the minor diagnostic criteria. So it might be that you're looking for that even in a structural heart disease. You can see how the QT behaves over the course of the day. There's lots of reasons to do a tape, and you can look for non-sustained VT, and it can be part of the risk assessment for a structural thing, as well as part of the diagnostic and risk assessment for an electrical condition. We use old-fashioned treadmill testing, so seeing what happens to ventricular ectopics on exercise, seeing what happens to the QT and the morphology of the T waves, those sorts of things can give you a feel for whether patients have a risk of arrhythmia, and it can be the cornerstone of a diagnosis. So again, slightly rarer condition, but catecholaminergic polymorphic ventricular tachycardia is one of the inherited arrhythmia syndromes, and the diagnosis of that is sort of bidirectional ectopics, potentially degenerating into VT during exercise. It can be a hallmark of long QT syndrome as well, to go into VT on exercise. So standard exercise tests are kind of maybe going out the window for a lot of indications in cardiology, but we do still use them in ICC for those sorts of settings. And then there's a few other quite specific tests that we do. Favorite MRCP Part 1 question is, what do you use to provoke Brugada syndrome? And most people remember Adrenaline for the duration of their MRCP Part 1 revision and then forget it, which is reasonable. But we do use Adrenaline provocation, so it's a drug that we give in increments to try and bring out a Brugada pattern. There's lots of different tests, and again, it depends a little bit on the context and what it is you're looking for.
Mm-hmm. I guess then, so that we're not just talking very broadly, if we maybe discuss the most common condition, which is hypertrophic cardiomyopathy that we kind of alluded to before, how much hypertrophy is enough to make you worry? Could this be hypertrophic cardiomyopathy? Because in this day and age with people, with hypertension, high BMIs, and all these different phenotypic features that can make this diagnosis difficult, what makes you worried as an ICC doctor?
Well, there are clear diagnostic criteria which are helpful in most cases. Again, just for context, as a general medical audience, 11 to 12 millimeters is the normal wall thickness of a septum, or any ventricular wall, really. And in that context of 11 to 12 being normal, 15 millimeters with some kind of lack of loading conditions, a lack of explanation, so no aortic stenosis, no hypertension, no high BMI, is what would be deemed diagnostic for hypertrophic cardiomyopathy. The exception to that being in a first-degree relative or somebody who carries a gene change that predisposes them to that condition, in which case the diagnostic threshold lowers to 13 millimeters. So you don't have to be very much thicker than the sort of normal population for that. You've hit the nail on the head in terms of diagnostic doubt, because there are a lot of patients, especially nowadays, who do have a high BMI plus minus hypertension. They might have moderate aortic stenosis in addition to all of that, and those are things that can thicken the myocardium. And I suppose there it's not so much about the numbers, it's a little bit more about the architecture of the myocardium. We spend a lot of time looking at blood pressure readings on the GP record, because just because somebody has a diagnosis of hypertension doesn't mean that they've had badly controlled figures. So if they're on a couple of agents and they follow the right lifestyle and all of their EP readings at home or ambulatory monitors are okay, you can't really blame the blood pressure in that situation. Whereas other people run a systolic of 170 for 10 years, have a BMI of 36, and have a little bit of degenerative change on their aortic valve, and that combination might bring you to diagnostic thresholds. And so for that reason, it's good to go through these things in a kind of MDT setting and, review the case notes in detail to understand the background in an individualized way.
You mentioned about looking at any gene results for these patients. So who would be subject to genetic testing of the patients that you see in clinic who have come in with query hypertrophic cardiomyopathy?
Well, I think if you've got a clear diagnosis and you're happy that there's no other loading conditions that explain the left ventricular hypertrophy, or, if there's a family history of it, for whatever clinical reason, whoever assesses them, based on their ECG, based on their context, based on their imaging, offers a diagnosis, then we will often then do a gene test. And that's now being provided increasingly by cardiologists rather than having to go through genetics, called mainstream gene testing. And in that situation, in around a third to a half of people, you can expect to find a mutation that explains the condition. If you don't, that doesn't mean it's not HCM. It just means that we don't have a molecular cause for it. So in that kind of scenario, if you've got a clear diagnosis, then it's in many cases very reasonable to do a genotype associated with the phenotype that you've discovered. There are certain situations where you might not be sure of the diagnosis and you can do a gene test. The problem with doing that, of course, is that if it's negative, it still doesn't exclude it being HCM. If you get a genetic mutation within that, then that potentially can be helpful. But as with everything, there are grey areas, and you might uncover a base pair change that doesn't necessarily cause disease, and that's called a variant of uncertain significance. And that's the kind of thing that's very difficult then to unpick when you start talking to a family about this genetic thing that you've seen in the blood and doesn't mean anything necessarily. It's very hard to then unpick what that means for the family. So I think in most situations, having a clear phenotype is the first step. And once you plus minus an MDT are happy with that, then offering a genetic test with the appropriate genetic counselling as to what each of those results means. You will then, in a certain cohort, be able to diagnose the genetic cause in that family. And then that may or may not have relevance to the person that you've tested, which is called the proband. There may be some things within that can change their management. But for HCM, there's very few things that would change the management. However, what you can then do is use the genetics to understand who's at risk in a family.
I'll come back to the treatment in just a little bit. I'm conscious, as you've mentioned, we've got quite a broad audience that listens to us. So would you mind maybe giving us an overview of the typical symptoms that a patient may have with HCM, if any?
Yeah, I was just going to say, often none. It's often incidental, and a lot of people live really well with it. They often have really good systolic function because they've got more muscle. It may be that they actually perform pretty well. A lot of patients with HCM are prone to obstruction to the blood flow coming out of the heart. So if you imagine the left ventricle, it has a sort of base which is quite close to the aortic valve, and then it has a mid-segment and an apical segment as you come a bit lower down in the heart. And at any level, you can have hypertrophy. So when the heart squeezes, the structures that are already a bit big can then start to come a bit closer together, and they can cause turbulent flow within the ventricle. And that sort of thing, I suppose it behaves a little bit like aortic stenosis or any other form of obstruction, in that with exercise, particularly when you're a bit dry and there's less circulating volume, people will often be prone to chest discomfort, maybe lightheadedness with exertion, often breathlessness. And the classic things from a history would be that it's worse on a hot day when they're dehydrated, or you get a gut rush after meals, and so postprandial exacerbation is something that you sometimes see with obstruction. So that's one kind of class of symptoms. I suppose the other big class of symptoms is arrhythmic ones. So if you're having ectopics, non-sustained VT, or even all these conditions carry a risk of cardiac arrest, then you need to ask patients about sustained palpitations, pre-syncope that's unprovoked, and particularly unprovoked syncope.
So would I be right in thinking that HCM can be kind of subdivided into obstructive and non-obstructive?
It's definitely a way of thinking of it. Obstruction can occur at any level and it can be dynamic. So if there's a substrate for obstruction on echo, but the patient's well hydrated, you might not see it on a day. And we try to do various things to provoke it. So we sometimes do a Valsalva maneuver during echo, or we can do stress echo as well, exercise stress, to look for it. It's a dynamic thing which may or may not be apparent on a particular echo or a particular assessment. That doesn't mean that it isn't the cause of their symptoms, for example. But it is one way to classify it. And people used to say HOCM, didn't they, when it was hypertrophic obstructive, and nowadays we refer to it more as HCM, but it's definitely an important part of the condition.
And I guess it's important to say that not all patients will go on to develop obstruction.
Absolutely. And if they have it on their ultrasounds or their MRIs, they're not necessarily symptomatic.
Given that most of these patients are asymptomatic, at what point do you intervene with treatment?
Do you mean for obstruction?
For either obstructive or non-obstructive?
A lot of it's to do with symptoms. So if you've got somebody who's giving you clear obstructive symptoms, or potentially, they can get diastolic dysfunction and get heart failure symptoms, then it's very reasonable to treat for those. A lot of obstruction is very treatable. And there's medical therapy, there's device therapy, and there's more invasive gradient reduction therapy as well. There's a big spread of things that you could do. In Leeds, part of our ICC clinic includes a nurse-led obstruction service, for example, because the treatment of that starts with lifestyle change if possible. So increased hydration, splitting your meals into little and often, exercising maybe after a little gap, after you've had something to eat. And then there's lots of medical therapies to start off with. So in terms of obstruction, generally the trigger to treat would be symptoms rather than having seen it on an echo. So if they're asymptomatic, there's no mandate to give them a beta blocker. In terms of treatment for other manifestations, so heart failure in any cardiomyopathy may require treatment. That can be diuretics for symptoms, and nowadays SGLT2 inhibitors have got a bit of a role across ejection fractions, and so that might be something to consider. With most cardiomyopathies, you would probably treat in terms of secondary prevention along standard guidance. So that's usually based on ejection fraction, isn't it, for most indications. HCM is a bit different because you should have a hyperdynamic left ventricle. And if your ejection fraction is normal, then it's probably a bit low for HCM, and that becomes a slightly less evidence-based zone. Our practice generally here is that if someone's got a normal or mildly depressed ejection fraction, we're relatively aggressive about getting them onto the usual evidence-based heart failure therapy. But our threshold is different with HCM because of that nuance to their ejection fraction. It doesn't always capture the true systolic performance. And I suppose the third class is arrhythmia-related treatments. And an ICD is a big thing to put in, especially in young people. And they're not risk-free. So we have to be very careful about case selection. There's two tools for this. There's the European Society of Cardiology, which has a risk calculator, which you can plug a lot of data in about the patient, and it gives you a bit of an estimate of their 5-year risk of a sudden death. So we use that a lot in Europe. There are also separate American guidelines, which are a little bit different, but some form of guideline structure can be quite helpful. It gives you a base to understand whether the risks of a defib would be expected to be outweighed by the benefits it might provide. And of course, an electrophysiologist is important because there are antiarrhythmic medical therapies and ablation and other things as well that can be used to mitigate that risk. Or put the defib in to give them a backup, but then try and stop it from going off by reducing the arrhythmias in a different way. So it's a very open-ended question, but there's lots and lots of different ways to manage the condition.
I know you've already mentioned about putting the ICD in and using the risk calculator to do that. Do you calculate that the very first time that you see the patient? And then how often would you recalculate that risk?
I think if you asked all the ICC doctors across the UK, we'd probably all say something slightly different, and it will depend on your resource and what goes on. I always calculate it at first diagnosis, or the first time I meet the patient, and I tend to keep an eye on it. But a lot of the information that's in it won't change. So you might get another echo for surveillance, and then you might find that the wall thicknesses have changed slightly, or the left atrial diameter, which is one of the things that you put in, might change. So you might have to be a bit dynamic about it, but largely you don't get large shifts in it. The things that change it are a new event, so finding non-sustained VT, which roughly doubles your score, or an unexplained syncope, or an affected family member passing away suddenly. So something like that might change it quite significantly. So when we follow our patients up, we will often do some degree of reassessment of that risk score and see whether it's changed materially. I don't think there's a particular mandate to do that on every assessment. Guidelines change from place to place and from year to year. And there are things in the guidelines, for example, you are advised to do an ambulatory ECG, for example, every 6 to 12 months to see if those risks are changing, and also to look out for atrial fibrillation. So you might find that forms a prompt every year or every 18 months or something like that to change your risk scoring.
And given how difficult these diagnoses can be, how long do you follow patients up for? Because I can imagine it would be very difficult to discharge a patient if you have this index of suspicion of something that's potentially life-limiting, but you still just don't have enough evidence to be able to give that patient a set diagnosis.
It's a challenge. I mean, we get a lot of referrals, and then every time you make a diagnosis, you create new referrals by creating a screening population with their family. But you're right, there isn't that much discharging that goes on because these are often lifelong conditions in young people. And actually, they're often not very life-limiting because a lot of them are low risk or that risk can be mitigated. So happily, a lot of these patients are alive for many, many years of follow-up. Then there's the people who don't necessarily have a diagnosis, and it's very difficult. I mean, I suppose it's an individualized decision, really. Again, we have a really strong MDT structure where I work, and there's a low threshold to discuss things like that to get a bit of consensus. But yeah, there is an issue around the fact that it's a kind of one-way street, ICC. You don't tend to discharge that many people. There are ways to do it. So a stable patient who has low risk, who's had the condition for a while, they've had a lot of their genetic testing done, family screening is underway, things aren't changing, stable on treatment, of which there are many, could potentially lend themselves to telephone follow-up, which is especially relevant because we cover a really big geographical patch here, just by virtue of what Yorkshire is like. We have people that might have to travel 2 hours each way once a year for us to say hello and not do anything. So sometimes we have been moving people in that kind of situation into telephone follow-up. We have other mechanisms for safety netting. So we have things like ICC nurse specialists who take calls if there's a problem. And that allows you perhaps to space out your follow-up a bit more. So you can be rational about that as long as you're auditing it and checking that that's a safe thing to do. There are patients, for example, who have dilated cardiomyopathy who we actually look after in the heart failure service once they've had their diagnosis. So there is a group of interested heart failure clinicians in Leeds who look after those particular types of patients, even if they've got a gene change and a family history. And they have actually been trained in genetic testing as well. So I think you have to make sure that that service is kept relatively low numbers in terms of the numbers of people to avoid variation, but you can envisage that perhaps the heart failure care might be a bit better, being looked after by a heart failure clinician with access to community heart failure nurses. So there's ways to redistribute the patients once they've sort of got what they need to out of the genetic aspect of the service. And that allows you time to focus maybe on more complex patients or patients where there's a lot of diagnostic doubt.
And you mentioned screening these patients. So to what level of the family does the screening extend to? Is it just first degree relatives or can it go beyond that?
So generally we go with first degree relatives to begin with. It depends a little bit on the inheritance pattern. So for example, if there's an X-linked condition, you can limit that to one side of the family. Mitochondrial conditions, things like that can be a bit more nuanced, but the majority of inherited cardiac conditions just happen to be autosomal dominant. So first degree relative screening is usually where you would start. And then of course, if you find something, let's say you find something in a brother, then that brother's kids might need to be seen. Or you find that it's on the mum's side, then you can stop screening dad's siblings and carry on a sort of cascade process of screening whoever's on the mum's side. So one of the first things we do is draw a 3-generation pedigree when we meet a new patient. And that can be done by anyone in the service, really. Historically, that was done during the genetic testing, and that was where the big pedigree was drawn. But actually nowadays, we do the gene testing within cardiology. And so we would make that assessment and define at that point who needs the screening. Sometimes you have to skip a first degree relative because they've passed away or they live abroad or they decline screening, and it's a very individual thing. But then the second degree relative behind them might still want to know. And our practice generally has been to consider offering a screen to those people, but perhaps being open about the fact that the chances might be a bit lower and you may wish to screen them a bit less often. But again, that's individualized.
And gene testing is always done on a blood sample, is that right?
You can do it on saliva. So in terms of people who are living, they can give you a cold swab or saliva samples, or they can give you blood. Most commonly blood. The other thing is you can do it on post-mortem samples. So if you have somebody who passed away either with a confirmed cardiac condition in life or on autopsy, then you can test tissue, particularly from the spleen, because it's got obviously a high number of replicating cells and therefore a lot of DNA to test. And there's a sort of national drive to try and increase the retention of spleen in those sorts of cases for the ability to do DNA testing. And we're working quite hard with pathologists across the country to try and increase the amount of tissue that is stored for that kind of purpose. If you don't have a diagnosis on postmortem, you can also do a wider panel, but you have to be a bit careful again of making sure that you do that in the right people and you have some idea of what you're testing for.
And my final question, I've been thinking, while she'd been given all this really valuable information, is about exercise guidance for these patients. And I appreciate that it would be down to the individual patient and to the individual phenotype. But I think, especially as junior doctors, we would all, well, I don't want to speak on behalf of everyone, but I think it's always safer to say don't do it until you've seen a specialist. Or it's best if you avoid X, Y, and Z. What would your advice be, other than perhaps looking up the ESC guidelines, so that's the European Society of Cardiology guidelines of cardiomyopathy that do have exercise guidance in there, but for someone who perhaps isn't that bothered but just wants to have an idea of exercise information for these patients, what should we be saying?
Challenging, isn't it? And I think from the position of a cardiologist or a physician making a diagnosis or likely diagnosis, it's really hard. You don't want to miss the opportunity to restrict exercise where it's really important. And yet at the same time, balancing that with the fact that it's probably a young person who's deriving a lot of mental and physical health from being physically active. We see the other side of it in the ICC service where people have had 6 months on the waiting list, they've detrained, they've become unfit, they worry about their condition. And then sometimes we tell them we don't think they've got cardiomyopathy and that it's all athletic heart. It's a very difficult thing. You're absolutely right. There are a lot of guidelines around, and I think when in doubt, they're very helpful. And there are groups in the UK who do a lot of work on this. Increasingly, the exercise guidelines are becoming more and more permissive. It depends a little bit on whether they're a professional athlete or whether they're an amateur athlete and what the kind of thrust and focus of their sport is. And it depends what sport they do, all of which is encompassed in the guidelines. It's very hard to give you a rule of thumb on this, Marilena, unfortunately, but I suppose if they're a professional athlete and they've got a condition that has a high propensity of exercise-induced arrhythmia, so arrhythmogenic right ventricular cardiomyopathy, long QT syndrome, CPVT, to name some, it might be worth getting in touch early with a specialist and just saying, what do you think I should tell the patient? I wouldn't feel that that was a waste of my time to be asked that question. I think there's a lot of relevance in getting that information and that counselling right. And it may be that that means we need to see them sooner, or it may be that we need to do, for example, we offer a regional MDT in the area. So we might ask for that to be discussed sooner so we can give some interim advice before the final assessment. We sometimes in our clinic will refer to a sports cardiology centre. We've got a few people locally who've got interest in the area, and we've got links with London and Liverpool. And we sometimes refer people to go and see people in those areas who have some knowledge of the area and up-to-date guidance. So it's not always an easy thing. The vast majority of people probably can do a bit of recreational exercise. The thing that I usually end up saying to people is that it's reasonable to do what we would suggest as moderate activity. How do you define moderate? It's a bit challenging, but I suppose being able to exert yourself while still speaking. But you might struggle if someone made you laugh, or if for some reason you were to sing during exercise. That's one of these things that people say, is that you couldn't imagine yourself singing, but you could maybe imagine yourself chatting. And for people who do weight training and things, it's about maybe focusing things a bit more on endurance. So a weight that they find relatively comfortable and they can lift several times to maintain muscle tone, but perhaps focusing less on something at the top of their ability level and can only lift a certain number of times. That kind of broad advice might be helpful to begin with. But I think on this particular question, if you're in doubt, it's worth checking in early and finding some way to give some maybe more nuanced interim advice if the guidelines don't kind of tell you what to do.
And I think you've highlighted that very well. There's no one rule fits all for these patients. They're all completely different. And that's why we do have these services like what you've described in Yorkshire. And I appreciate that everyone will be slightly different, but I doubt any ICC service wouldn't want to provide information for these patients to juniors who are perhaps a little bit worried about how to manage them.
I think so. Certainly that's been my experience when I was always on the other end before I started specialising in the area. I never found it difficult to refer in. As someone sat in Yorkshire with a lot of very specialist quaternary services in London, I never feel as though there's any judgment if we ask questions. It's a relatively small community, so we do end up asking each other questions and bouncing things off each other. There are guidelines around, and in terms of patient resources, there's also a lot of things that you can signpost the patient to. So British Heart Foundation, Cardiomyopathy UK, Arrhythmia Alliance, there's various places, and some of these even have helplines. So it might be possible for them to get some help on their own or go to patient groups and understand a bit about what to do with their condition before they come to see you. Always challenging when you don't have a diagnosis. If, for example, you're very happy on the diagnosis, you're working in a secondary care centre on a rotation, and you know it's HCM, then you can start that signposting. If it's in doubt, then most of these charities will also entertain discussion and provide support, even if the person doesn't necessarily have a clear phenotype.
Perfect, thank you. For our listeners, I'll make sure that links to those sites and charities are on the footnotes of the podcast. So thank you for that. I think I should probably stop asking you questions now. I probably got to the end of what I had to ask. Any final closing remarks for anyone listening to us, either thinking about ICC or worried about patients with inherited cardiac conditions?
I suppose this probably targeted more at people that are doing cardiology, your question. I think if you're in doubt, if you want to be involved in training or if you want to experience a specialty, find out who does it locally. And if it's not available locally, find out who does it next door in the nearest city. Most of us who do it are generally pretty keen, actively got into it. It's not really the end point of most subspecialty training in cardiology, as you know, Marilena. And so it's something you make an active choice to do because you're interested. And there's usually a way to find someone who's keen to teach. For people outside cardiology, I think in these situations, it's always good to get a friendly cardiologist to help you out because these are unpredictable, relatively rare, a bit nuanced and very individualized. And they'll be able to help out with, who needs referring, who doesn't, and how best to tackle the genetics aspect of things.
Perfect. I don't think I can say anything to end that any better. So thank you so much for your time. Thank you for all your advice. For all our lovely listeners, thank you for listening to us again. If you are interested in cardiology, then there is obviously the Career Conversations podcast in cardiology. We also have a medical genetics one in Career Conversations, and we hope to see you soon. Thank you so much. The TNMC sister podcast, Career Conversations, supports medical students and trainees with career guidance and progression, as well as professional development. We wish to recommend our Demystifying PACES podcast series on career conversations. As some of you may know, in late 2023, MRCP UK updated the PACES exam format, so we developed this new series to support PACES candidates. Episodes cover exam organisation, calibration, every PACES station including key changes, and candidate perspectives.